Worcester and Norfolk. Mr. Moore.
Thank you, Madam President. I hope the amendment is not adopted. Madam President, I have great respect for the folks that have spoken in favor of the concept of single-payer health care. Most people, when they hear single-payer health care, means someone else is going to pay for my health care. Well, what it means is the government is going to pay for your health care. What does that mean? Where do we get the money for the government to pay for anything? We raise taxes. And a study was done when the gentleman from New Bedford was the chair of Ways and Means 10 years ago. It doesn't seem like it's been that long, but yes, it has, and yet he still looks just as young today as he did back then. No gray hairs at all from that laboring in the Ways and Means Committee. And we had a study done that was actually appropriated $100,000. I suspect 10 years later the cost of the consultants would be a bit higher. But we had spent $100,000 on an independent study. It was by a consultant that we asked to do studies of benefits and other legislation that comes before the Division of Healthcare Finance and Policy. And at the time, the cost was actually going to be higher than health care costs at the time if you looked at what we were paying in Medicaid costs. But it also would have meant a shift, significant shift, in taxes. Some people might pay less in insurance, but I would point out that most of the European countries that have a government-sponsored health plan also have an insurance market because the government plan doesn't always do what everyone would like it to do or when they would like it or think they need it to do. And so they still have insurance costs, and so there still have to be insurance companies, maybe not quite as robust as they have been in the United States in recent years, but they still would have to exist. It would require an expansion of the personnel in the state government to handle a much larger policy. Single-payer health care doesn't do anything about the cost of health care. That's what we're trying to do, and so this bill does not complement what we're trying to do here. It would, unfortunately, tie up an agency that we're asking to take on some additional roles of analysis of costs of the health care system and helping us to get it down to a reasonable level with a project that is very doubtful in the end because it requires not only a significant increase in taxes, and we're talking several billions of dollars more in revenue to pick up the cost of health care that's now being paid for through the insurance premiums and the other part of it through the self-insureds who aren't necessarily able to be covered by this without a change in federal law, the ERISA requirements. But it also would require significant waivers from the federal government in our Medicaid utilization. A federal government that under the current administration, a Democratic president, and at the time a Democratic Congress when the Affordable Care Act was passed, when that administration and that Democratic majority rejected the concept of a public option. And I'm pretty confident that should the White House change party and the majority in the Senate change party, that new majority and that White House would not be advocating a public option. That's been pretty well explained by every candidate who carries the Republican banner, that that's not something in their game plan. So I would think we would have a very serious difficulty after spending all this time and money and effort taking away from the work of that agency and helping us to get costs down to, even if we were to pass, and I don't know how many people here, I know there's some that would vote tax increases, but in the billions of dollars, I'm not so sure we'd have any great profiles and courage doing that, casting that particular vote. And even if we did, there's some folks across down in the back of the building here who have made it pretty clear that they're not, at least at this point in time, willing to increase costs and increase taxes, and certainly not for something that's already being provided through the economy but needs to be tightened up. The gentlelady from Somerville and other parts of the Commonwealth said it doesn't compare us with other countries. Well, yes, it does. The language of the amendment says the Institute shall monitor the performance of single-payer health care systems in other states, and there aren't any, and in other countries. So it would compare us to Canada, it would compare us to every other country that has that system. How do you how do you get an agency, bureaucratic agency, to come up with an estimate of what a single-payer health system would do as compared to what the benchmarks that we're putting created? It's pie in the sky. It's really not realistic to expect that you could have a meaningful answer. Sure, you can have a lot. You can say, well, it might be this way, and if it were this way, this is what it would cost. But that's not necessarily what's going to happen. That's not necessarily what the legislature who's in office at that time will do. We don't know what the mechanism, the administration of that would be. Now, if we were to, when the study that was done utilized two things. One would be, what if we essentially extended Medicaid to everybody in the state? Take away the wealth requirement for those above the federal level, because it would be 100% state funding, because the federal government has not indicated any willingness to partner in this mechanism at this point, at least. And if we did that, the average person isn't going to, first of all, the average provider is not going to accept Medicaid rates for all of their patients. You might find a doctor who's willing to give up most of their time and go to the darkest corners of Africa or Asia and practice for essentially no money, but I haven't run into a lot of those doctors around, so I don't think we're going to find most doctors willing to work for what they would get reimbursed under that system. Nor are the hospitals certainly going to be able to maintain the level of care that they provide under if the rate was a Medicaid rate across the board, largely state-funded at above the poverty level. And so we would have a system that would certainly not provide the level of benefits that we even provide Medicaid. And you know, talking to your constituents who have private insurance, that how much more they want and how much they insist, and sometimes they're right, but insist the insurance companies do more for them. They're going to want the Commonwealth not only to do more than the insurance companies, they're going to want to have anything. There will be no cost control. You know how hard it is to have constituents come in and demand whatever service it is, as they do around budget time. It's not easy to say no, and we don't like to say no. And we would be on an endless spiral of increasing costs, which we have to increase taxes to do that. It sounds great on paper, but it isn't realistic, and the study that we had showed that it was going to be a lot more expensive than people thought. There was a huge shift in spending and a major change in employment of those folks who are now working for the insurance companies. Many of them would probably end up becoming state employees, and you know how thrilled the media and some of our constituents are with any public employee. And so it would become a huge battle and a lot of effort at a time when our economy right now is not the greatest. We hope it's going to get better in the next few years. It's all our hope and not a guarantee. There aren't many guarantees in life, and this is one that's certainly no guarantee that it will solve our problem. And I'm concerned that the amendment, while it doesn't, as many have pointed out, it doesn't automatically trigger us into a single-payer system, but it puts us on a course that some people are going to demand. They're going to figure this is now an inalienable right to have a single-payer system because we even studied it. They did the last time, and I think they will again. It is not a wise use of our state resources at this time to have an agency that we're giving a lot to do to study something against a benchmark that is as squishy as you can think about how we would compare it. It is an errand that is not worthy of study by the state. And if people really think they want to get a good study done, then the advocates for that program should come up with the money and pay for a study. That would be a start. But nobody wants to dig in their own pocket. They want to dig in our pocket collectively, the people's pocket, in order to pay for even the study, let alone the huge shift that it would result in. The state of Vermont, which is not exactly the same as the state of Massachusetts in population or culture or anything else, and does not have the number of providers or payers in Vermont, but they are looking toward this system. But there's no guarantee they'll get there either. But it's not until 2017. Well, there's a great pilot project right there called the Green Mountain State. Let's see how they do it, if they can do it. And then if they can, let's see if it can be replicated. I don't think it can, but I don't think now's the time to do that study. Let's give Vermont a chance to see whether they can achieve what they think they can achieve. And then if it looks like, if they actually can do it, and I still don't know that they can, even with their much more insular population, that then it's maybe time to look at it. But I frankly don't think we can do it as a single state, and I think Vermont will find on all those Green Mountains there will be a lot of new houses from people in New York and New Hampshire, where they've decided they might want to live free in Vermont rather than die in New Hampshire. And they're going to move over to Vermont. And who's going to pay for that? Whoever the taxpayers are going to pay for it. If it were done as a national plan, at least you wouldn't have that cross-border shifting. In fact, we looked at, there were a lot of folks that argued 15, 20 years ago that we had a welfare system that was far more generous than the rest of the country, and that people were coming here by the busload, and some folks said, well, we should give them a bus ticket and one way back to wherever they came from. Well, when the rhetoric was cut away, it appeared that, on average, the welfare benefits in Massachusetts were about $5,000 a year better than the nearby states. Probably not really enough to attract an awful lot of people to the state just for that purpose, because we also have high costs, so they still would have to put up with that. But when you're talking health care, you could become, because you'd be eligible as soon as you cross the border and set up residency, you could have a bill. Who would come here? If you're sick and you need a big operation, and especially if federal health care were to be terminated by the court or by Congress, the burden would be substantial. People come to Cape Cod. Now, if there's still a Cape Air at the time, because that business will be heavily taxed on top of the fuel costs, if there's still a Cape Air, they'll be flying in. They won't be flying out. And you'll be building more homes for the underprivileged on Cape Cod, because everybody's going to want to live in the best places. And it'll maybe help the housing market, I suppose. That's a thought. But unfortunately, they're going to be sick people. And they're going to come because they don't want a home here. They just want a hospital bed or a nursing home bed in order to have someone take care of them. So it's a great idea and concept and thought. Maybe on a national level it could be practical. It has been practical in other countries, although they have different heritage and history than the United States. But perhaps it could work on the national level. But we would clearly put ourselves either in bankruptcy, or if people think taxes are high, and actually, despite the fact that my friends on the minority side sometimes want to say the state is so heavily taxed, more recent statistics suggest we're not Taxachusetts anymore. I know, and that one says right about in the middle, 23 or so rang instead of number 1. Only when you add the federal taxes in, then because that's on a sliding scale, and so federal taxes are much higher collected from us, from our folks that are, all of our 1%ers that we have here who are able to pay that money. They should pay more probably, but nevertheless, the direction that this study would take us is wrong. It will destabilize both the insurance and the health care provider system if we're even talking about it seriously. One of the things that this bill tries to do, and that business tells us they need, is some sense of stability. We're trying to give them that sense of stability over time, over 15 and longer years in the bill, as to what the costs will be, and then there's another study proposed in this amendment to totally change the system. That's not going to advocate for stability of our economy or of our health care system. And I would hope that, as well-meaning as the amendment may be, that this is not a study for the state to take on again at this time. The study in 2002 said that a single-payer system would cost upwards of $44 billion, and they account for the savings that they think might come with administrative costs, which was about 5.17%. And so the overall system would be $44 billion, but if you pay at a reasonable rate, not at the Medicaid rate, it would be $48 billion. That's in 2002 dollars. There was more support then for the single payer because we didn't have our house in order with health coverage and health insurance. We have done a proposal in 2006 that became law that has over 98% of our residents covered. We further refined that and improved it in 2008 and did it again in 2010, particularly focused on the small business community. A lot of those, some of those provisions are still in the process of being implemented. The estimate of the consultants at the time was that even if you voted to change to single payer, and if the people did not put everybody on a train out of here, every elected official in the legislature, certainly out of office, if not out of the state at that time, we would, and if we could tax people high enough, like they do in some countries, Greece particularly is a good one, where they don't get their dollar's value for what they need, we would find that this system will not work. I think if somebody else wants to pay for it, fine. I don't think the state should at this time. We've got too much to do to get costs under control. We should let the Institute spend their time doing that and not studying something that is not likely to be something that the public, when they know what it's going to cost them, net costs, and what we know they will demand no matter what we give them in the way of benefits, they will want more and figure they can get more because now they're running the insurance program. They're running the state. And the cost will escalate tremendously. We won't, barring some miracle in Washington, we won't get any federal help to do it, and even if they give us the authority to do it. So I think it would be foolhardy to adopt the amendment. It would be certainly a problem to go on and adopt it with the specific triggers and mechanisms and the comparisons that we're telling the Institute they have to use to study. It sets up a study mechanism that is not balanced, is not reasonable to really get at the full cost, because it does not look at what the shift is needed in taxes to pay for that system. We're looking for ways to cut taxes. We're looking for ways to cut insurance and have more cost efficiency. This does not do it. It sets up another mechanism that I think will hugely destabilize the economy of this state and will send a message to people who want to come here and want to grow their businesses here that this is not the place to do that. I hope the amendment is not adopted.
From Bristol and Plymouth, Mr.